So now this is our last talk in what has been a fantastic session. This is David Eberts, who's presenting to us on predictive patient factors impacting lower extremity dialysis patency, a tool to guide decision-making for creation of new arteriovenous access.
Thank you. Good morning, everyone. I'm David Eberts, a fellow at St. Louis University. And I'll be talking about something we don't talk about often, which is lower extremity dialysis access, and then hopefully trying to create a subset of patients and a tool of how we can figure out who best would benefit or not benefit from this, utilizing what I think is some fun math. As we all know, the long-term durable access that is best for the majority of patients is in upper extremity AV fistula. The patency is up to 70 and 80% for primary and secondary. However, for a significant subset of our patients, after extensive work in their upper extremities, a last resort option becomes for the surgeon and the patient to consider a lower extremity access. The more common ones done are usually a upper thigh AV graft, a loop mid-thigh, or for a fistula, a transposed femoral vein fistula. We all know that the breakdown and the infection risk is much higher in these lower extremity accesses, up to 20% in some studies. But what's not really well described is how durable are these accesses, because there's very few data out there, and the range for their primary and secondary patency is huge. At 1 year from 34 to 94%, with secondary patency 18 to 85%. So it's really unknown how good are these options for our patients. Probably the best study that is out there right now was done in 2019, where they studied 460 patients with lower extremity access. They were only able to go out to 6-month outcomes, and that was a primary patency of 52%. And importantly, they found no difference between AV fistulas and AV grafts in the lower extremity access. Thus, our aim was to look at the primary and secondary patency in a much larger cohort of patients to better delineate what actually is the long-term durability of these accesses, and then can we risk stratify who would most benefit from it. We did a retrospective univariate and multivariate analysis. Our two cohorts were AV fistulas and grafts in the lower extremity. We looked at just primary and secondary patency, and after the usual survival and multivariable Cox regression analysis, we'll then go through the risk stratification tool creation and a validation of that tool. We utilized the VQI, which now has almost double that largest study in terms of the actual accesses that we could look at, with AV fistulas being 239 and AV grafts almost 1,000 patients. And this was from 2011 now to 2023. The overall demographics are not surprising that all the arrows in red are for the AV grafts, that those patients are older, have higher area deprivation index, and more likely to be non-ambulatory. However, the rest of the demographics were pretty equivocal. When we look at patency, primary patency at 1 year, we saw that AV fistulas had a patency of 60% and AV grafts 40%. When we tried to look at the differences between them, our curves didn't match the hazard proportional analysis assumption, so we can't really say there's a difference between them, but we can see that the range is maybe 40 to 60% for lower extremity access. When we look at secondary patency, which the VQI does note is much more of a better time point to look at for dialysis patients in the VQI specifically, we do see that AV graft has a lower secondary patency, from 88 for fistulas to 74 for AV grafts. And thus we decided to spend most of our time on this, secondary patency, which is the best well-tracked data in this subset, and then looking at AV grafts, because as stated, the large majority of these patients were AV grafts, not AV fistulas. So the secondary analysis was a multivariable analysis of just lower extremity AV grafts and looking at the risk factors for loss of secondary patency. When we did our multivariable regression, on the right is the full hazard ratio tables, but on the left I've summarized the important things, that as length of stay increases, as age increases, as BMI increases, if someone has PAD, interestingly, if they're non-diabetic, if they've had no prior AV fistulas, or if they have had prior AV grafts, all those things are associated with an increased risk of loss of secondary patency. This is then how the scoring system was developed from those hazard ratio numbers. This is kind of at a large scale view, and also where the math gets fun, I think. So the first thing you do is you standardize the coefficients using a log scale. Then you scale it down to the lowest reference value, usually taking your beta of your index for each value and then going to your smallest one. assign score values so that you can actually score the patient, and then validate the model. This is a very similar model to how many people have developed tools in the past, such as the MELD score or CHAD-VASC was very similar to this subset. For actually validating the model, I decided to use a split model validation, which is basically where after you've done a machine learning study, you split the model A into training, usually about 2/3 of your group, and then you test it on the remaining 1/3 and take a concordance index. I use the Harrell's concordance index to see how well does that model fit the actual data set. So this is it in real time. So the hazard ratio, let's just look at the top one, length of stay, hazard ratio of 1.18. Then we take the log of that, bring it down to 0.07. We then scale that, and I used that as the lowest one, so that became a log of 1, and you can see all the other categories being scaled accordingly. And then to make it a clean value, made a score that's a solid even number that you can then actually calculate. So using this score, it adds up to a total of 74. I took a histogram of all those 900 patients that we had of AV grafts, and I saw that the 50th percentile was around 50, the score of 50. So then I took the standard deviation to the left and right of it to create basically 4 subset of patients in terms of risk of secondary patency loss, such that if you scored anywhere from 0 to 40, you have a pretty good chance of maintaining secondary patency. But as soon as you get above that 55% risk, your 55 score, your risk of losing secondary patency within a year gets extremely high. So then the validation model, I'm just showing it again, ran it where I split the model into 2 subsets, trained it, and then tested that trained set on the remaining population, and I got a concordance index of 0.79. Most people will aim for anything above 0.7 to consider good. Above 0.8 is excellent. So we were pretty happy with this number. And this is the final tool cleaned out, that you would calculate your score on the left if you were pushing this in on your phone, such as on MedCalc, and then you could then talk about the actual risk of this procedure working well with your patient and whether or not it's a low, medium high, or high risk of losing secondary patency. The next steps, and obviously the limitations, is that to create a tool like this, the first thing is to do an internal validation like I did, but really to make this robust, I would need a separate data set to do an external validation. But overall, what we conclude from this study was that lower extremity dialysis might have, not necessarily equivocal, I think that's a strong word, but better patency than most people think of. However, we do know that there's still a high risk of infection and wound breakdown. And there's definitely a subset select patients who can have a predicted success or failure, and potentially a scoring system like this can help guide clinical decision-making and patient-shared decision-making. Thank you.
No questions from the audience? I don't know, we're a bit behind time, so I guess in the interest of that, thank you so much for your talk. I will also echo that this was a great session, really a lot of engagement. The fact that we had to cut you guys off multiple times shows that everyone's listening and excited about the data. Please stay tuned for the artificial intelligence session coming up now, and we'll see you all later.
Thank you.